So the first session today is by Professor Leiden Taphoorn. Professor Taphoorn has obtained his MD at Leiden University and subsequently specialised in clinical neurology in Amsterdam VU Medical Center, where he also wrote his PhD thesis, Treatment of Primary and Metastatic Brain Tumours, Beneficial and Adverse Effects. He further specialised in clinical neuro-oncology at the University Medical Center, Utrecht, and during a sabbatical leave visited DeAngelis Cancer Center in the Memorial Sloan-Kettering in New York. Professor Taphoorn is going to speak to us today about patient-reported outcomes and advanced care planning in brain tumour patients, the importance for patients, caregivers and clinicians. Dr. Taphoorn. Thank you.
Thank you very much for this kind introduction and for the organization to invite me to come here and to speak to you. It's really an honor and a pleasure for me to speak to you as patients and caregivers for brain tumor patients. And I'll try to make clear what we are doing with our research, our clinical research for brain tumors and their families, and the importance of outcomes that are relevant both for you and for healthcare professionals. So let's start off. In summary, I try to summarize what we think is important for brain tumor patients, what we want for our brain tumor patients. For sure, we would like them to live as long, but also to maintain their quality of life, their functioning and well-being during their lives, to reduce symptom burden due to the disease, but also to limit the side effects of the treatment that patients will get. And finally, and this is not last but not least, I would say, to deliver the care in line with your preferences and your goals. That's what I think we should do as healthcare professionals together with you. And let's go on and see how we can organize this and how patient-reported outcomes and advanced care planning can help with this. If we look at information that we get from big trials that we can inform you about on what's the best treatment, I think we traditionally looked at survival, how long is the survival in one group as compared to the other treatment, and looking at results on scans, which is important if we see a reduction of the tumor for sure. But I think gradually we also acknowledge that it's important to look at other outcomes in patients with brain tumors when they are under treatment. Their symptoms, the impairments that you may encounter, the functioning in daily life, and what we call the healthcare, the health-related quality of life, which is a sort of term which is covering many effects, symptoms. It's on your functioning, it's on your social functioning, on your physical functioning, on your psychological functioning, and it's an umbrella term for this health-related quality of life. Now, if we try to capture what is important for these outcomes, how we can measure this, how can we determine what is how your quality of life is, so to speak, we have a set of assessments, what we call clinical outcome assessment. And this is an umbrella term what was devised by the American Food and Drug Administration, which covering several aspects. And the main thing is the patient-reported outcomes, but because that's what I'm going to discuss today, that's the outcomes that are reported by you, and that we are thinking is very important to know. It's mainly on quality of life, but it's also on symptom burden. It may be on your subjective functioning, on your cognition, so to speak. And there are other measures that we can take in this clinical outcome assessment that we as doctors or as any healthcare professionals can measure your functioning. We can do cognitive testing, for example. So these are also very relevant clinical outcome assessment. But let's focus on the patient-reported outcomes. And it is about patient perspective. That must be very clear. It's not about what we as healthcare professionals think how you are functioning. It's about you are judging your own function. And how do we do this? We have developed questionnaires. There are several standardized questionnaires, for example, by the European Organization of Research and Treatment for Cancer. Also the Americans did this, and there are a lot of local initiatives on questionnaires or semi-structured interviews to do this. And in the end, what we try to capture is, if you have a clinical trial with outcomes that are traditional, like survival duration, we also see there's something else, which is the impact on patients' functioning. So we have to weigh the balance, because it may be that the treatment is effective, but it's also harming you as patients. So we have to find a balance which we think is the best way to go, and discuss this with you for sure. We can also look at this in clinical practice. We can also, during your journey, your treatment, your follow-up, we can study how these outcomes may vary over time. And we can ask you to fill out these questionnaires every time you come to the hospital to hear the result of the scan, but also to hear the results of the questionnaires, because we think we have to bring them back to you. My experience is that you're willing to help us in getting this information, but we have to give you the feedback. Otherwise it will disappear in a large database, and you say, well, it's nice, but it's anonymous, I want to know it for myself. So we know it's very important that we, in clinical practice, that after getting this information, bring it back, we can have a real discussion on how you are doing. And we can also discuss what is specifically important for you. And we as healthcare professionals are more easily understanding what we think is important for you. And actually research, clinical research is demonstrated by doing this, by giving back this information and discussing with you how things are going and how we should adapt treatment or give you supportive treatment. It will improve your functioning and quality of life, and even may lead to a prolonged survival. So it's really helpful. But again, we have no idea yet how it may impact on our management and clinical decisions. And that's the second thing, what we call the advanced care planning that I'm now going to talk about, which is something that I would like to discuss based on the history of a patient of mine. It's a woman of 46 years old. She was diagnosed with a glioblastoma, and she had her treatment. She did well for some time, but then she had a recurrent tumor. She had a second surgery and radiation for a second time, and then we had no more treatment options. She was doing relatively well at that time. She had some dysphagia, difficulty in communication, but she could manage to take care of herself, live at home independently. But unfortunately, one day she was walking in the street, she stumbled and she fell down, and she didn't lost her consciousness, but she was unable to get on her feet again. So an ambulance was called, and due to her communication problems, she was not able to make very clear that she wouldn't like to go to a hospital being transported by the ambulance to leave. But you know, if there is no information there, if there's no one there, and the ambulance is there, you see a patient on the street, and so in the end, she was transported to the hospital, which was very, in that sense, for her unlucky. She was at the first aid department, she had her examinations, there was nothing really wrong, probably she had fainted, it had nothing to do with her disease, and she could go home again. But then you can ask yourself, how did this happen? How can we prevent this? Because that's something that was happening against her will. Why was she taken to the hospital anyway? Was it not known? Could this have been prevented? Others to know it, or she maybe have something written down. Were her preferences in the medical file, and was there any family or relatives or others involved in this decision making? And these are very important questions, we believe, that are very important to try to capture for patients and their families, and what we can call as advanced care planning, which is in a sense a process of sharing with patients and caregivers and defining your personal values, life goals, and your preferences regarding the treatment and also the care that you get. Advanced care planning is a well-known, I think, phenomenon that we see in general care, in elderly patients, in oncology for sure, but also in brain tumor patients. And specifically, we think it's important for brain tumor patients. I'll try to explain why. First of all, how does it look, advanced care planning? You have to talk to your patient as a healthcare professional. Would you like to know what this is, and when during the treatment or after treatment that we're going to discuss this? Do we have to report this in your medical file, what your preferences are and your wishes are? And do we have to discuss this again, because it's something that's transforming over time, it will change and you have to come back. So it's an aim that the people receive the care that's consistent what they wanted, what their values and their goals and their preferences over the course of the disease. So to give you some examples, for sure you want to go to the hospital if something is happening to you, like the patients that fell over on the street. You want to be hospitalized in your end-of-life phase if there's a problem, or you want to stay at home or in a nursing home. What's your preferred place of death? In the Netherlands, most of our patients die at home, fortunately, or in a hospice, but not in the hospital, or not in a nursing home, preferentially. Are there any alternative routes for medication in the end? It's not by, if you can't do it by take it orally, how can you give the medication, which is helpful for patients? Do you want do not resuscitate orders? Do we have proxy family for surrogate decision making? Who is going to speak for you if you're not able to do this anymore? And things about pain relief and wishes after death. So these are just examples. There are a lot of things that you can discuss with patients. And I think particularly in brain tumor patients, it's important because one of the problems in brain tumor patients over time is that we see that their medical decision capacity will decrease over time, which is due to the fact that you have the disease in the brain, which may have impact on your cognition and your medical capacity during the treatment phase. And we did a review led by Andrea Paartje on this issue in brain tumor patients, and we do know that up to half of our patients during the course of disease have reduced decision-making capacity. Because decision-making is first of all understanding, then appreciate what it is, reasoning, what are the pros and what are the cons, and then making the final choice. And for this, you need a brain that is, well, more or less intact, so to speak. We do know that there are a lot of problems that may encounter, like dysphasia, loss of consciousness, that may impact your medical decision-making capacity. And in the end, if you have the advanced care planning and you have all this written down, it makes it easier for you to have these decisions in the end, and even if you're in the end with a reduced capacity, medical decision capacity. Our own research in Leiden in the Netherlands has shown that the somnolence and the dysphagia in the end-of-life phase are very prominent symptoms in brain tumor patients, again pointing that you would preferentially have to discuss all these issues before in order to prevent that you're not being able to be engaged in it yourself, but you should leave it to your family. And we also know that the competence in the last weeks and last days is going down, which is then also reflecting the fact that in brain tumor patients we see that the medical decision capacity is becoming less, and advanced care planning is something that should be done earlier in the disease for sure. So if you looked at the traditional way of how do we deliver care for patients with a brain tumor, from the end, I think in most of our brain tumor patients, it's part of curation, curative treatment, but palliative care, palliative treatment is there also from the start. And we see that the advanced care planning is something that can be discussed and implemented over the treatment and follow-up period, but preferentially already from an early phase in order to prevent that you are not being able to be engaged in this. So once again, first of all, we have to find out if you're ready to talk about this. We have to re-evaluate this over the time. We have to discuss it with your family, your caregivers, other surrogates, to record this and to put it in medical file. These are important steps in the process. And we did in the Netherlands a small study to start with in glioblastoma patients to see if we can develop such a program, because there are a lot of initiatives on advanced care planning, but something standardized that can be really helpful, both for you and both for us, wasn't yet there. So what did we do? We started to evaluate the implementation of the advanced care planning in clinical practice, mainly about the content of the program, what is exactly important for patients with brain tumors that should be in the advanced care planning program. What's the optimal timing? Should we do it from the very start when the diagnosis is there, or should we wait until the initial treatment has been given? What moment? And how does it impact the functioning of patients and their families and the satisfaction with care? Because it's very hard to measure the impact. What outcome should you exactly choose for this? So this is something that we try to figure out. So what we actually did, we invited patients shortly after the chemoradiation period to participate in this program, and if the patient, and preferentially also the proxy, the partner, would agree to be involved in this, we supply them with a specific folder that we developed to describe what the advanced care planning, what the topics are, just in brief, just to give the ideas, like I put it on the slide, what the topics are. And if then they would be willing to discuss it, we schedule 2 sessions with a trained facilitator to discuss this, which took about 1 to 2 hours, 2 times, and the patient and the partner could specifically indicate, I want to talk about this, and I want to talk about that, but I do not want to talk yet, or maybe not at all, about something else. You know? So it's very important. It's tailored to what the patient's preferences are. And we encourage patients to write something down on what they decided based on these sessions. And we also try to, again, when they visited the hospital for scans and things, to discuss, are you still happy with what you decided? Should we reevaluate it? Should we contact your house doctor about it? How should we go on with this? So the thing that we as doctors discussed, and we had a team of doctors and also other healthcare professionals like specialized nurses to see what is the optimal timing to do this. And for the healthcare professional, it was clear. It was after the chemoradiation. We thought, let's first give them the treatment. Let's not start at the first discussion about the treatment at the same time discussing about the advanced care planning, because it may be something which is not really helping. It makes you as patient, in our view, think, what does the doctor want? Does he want to treat me or does he not want to treat me? So we thought, let's leave it until after the chemoradiation and then discuss it, and hopefully the patient is still able to work on this with us. But if you look at the left side, you see that the patient and the proxies and the relatives had other ideas. To some extent, they did agree with what the doctors said. Yes, let's do it after the chemoradiation. But we see a large portion of them thought we should immediately do it after the diagnosis. So that made us think that we should bring this program more from the start after the diagnosis and not to wait too long. That's one of the things that we found out. Was it acceptable to patients and caregivers to discuss all these critical issues and sensitive issues? Yes, it was. In most instances, I think they accepted it. And that is also based on the fact that they were able to decide, I want to discuss specific topics and I do not to discuss other topics. That's very important. We also found out, unfortunately, that we didn't find an impact on the patient's functioning and well-being due to the ACP, to the advanced care, which we'd hoped to find, or change in levels of anxiety and depression, which was a bit, well, we were a bit frustrated that we couldn't find, but we do think we should look at other things. We did find from other studies in advanced care planning in advanced cancer, more in general, that also in these publications there were similar scores on quality of life. But what we do see, and also in our patients, that the patient satisfaction is increasing if we apply this program. So it's more on patient satisfaction than patient's quality of life. It is now that we are trying to see, based on this initial program, that we would like to engage on a larger trial in the Netherlands with several centers, and we are still thinking, should we do a randomized study, so to speak, that we should give patients, based on randomization, the standard treatment or standard information on palliative care and end-of-life care, or should we engage them in an advanced care program? But then again, what are the issues that we have to address in such a research plan? Because we should look, for example, at how frequently is this patient hospitalized in the last phase when the advanced care planning has been applied, or what's the satisfaction of care. So there are a lot of things that we are looking for to see what is the best outcomes that we should look for that are helpful
for us, and for sure also for you, to work together on how we should continue this advanced care planning in brain tumor patients. So this is my final slide. This is the hospital in Leiden that I'm working at as a neuro-oncologist, dealing with brain tumors and their families. For sure, I'm not the only one, and the research that we're doing is with a team. We have a team of neuro-oncologists, of epidemiologists, and dedicated PhD students, but also with dedicated nurses who are helping us in this area, in research and in patient care. And I'm open to have discussion with you on this. We can do this, I think, later on in the session. But I'd like to thank you for your attention.
Thanks, Thank you, Professor Taphoorn.